Welcome everyone. This is the introduction to the Department of Human Services Opioid Prescribing Quality Improvement Program. My name is Sarah Wren and I am with the DHS OPIP team, and I am joined by my colleague Jessica Halkren, who is going to be helping moderate the question and answer session. And then our colleagues at ICSI will be joining us for this call today as well. I've already introduced myself. I am one of the coordinators of this opioid prescribing improvement program at DHS. And then Audrey Hansen, who is the team director for this project at ICSI, will be presenting the second half of the content. Our meeting objectives today, I will provide a brief overview of the DHS opioid prescribing report, an overview and a timeline of the 2021 Quality Improvement Program, and then go over what the available supports are from now until the end of the year. And then Audrey will take over and provide information on finding information to better understand your whole practice as part of this QI project, the recommended standards and processes, and then a process for requesting a special cause clinical review for the QI project. We like to start out most of our talks on this project just touching on the goals of this work. This work has been going on for about 5 years now. We're really still invested deeply in prevention and how it applies to the opioid epidemic. So the first goal is to really prevent the progression from opioid use for acute pain to chronic opioid use. The second goal is to reduce variation in opioid prescribing behavior among peers. And then the third, which is very near and dear to our hearts, to clarify best practices of opioid prescribing to ensure patient safety while providing appropriate pain management. Okay, I very much hope that this is something you have all seen before. This is the DHS opioid prescribing report. Everyone on this call hopefully has seen one of these reports, whether it's yours or whether it's someone in your organization. There are a number of reports, so this is just intended to give you a snapshot of what this report looks like and what we're talking about today. If you haven't seen one of these reports, please contact us. We can get it to you. We can get you your report, or we can get a sample, or we can clear up any questions you may have about this report versus PMP reports. So I'm going to just go through a quick few reminders about the DHS opioid prescribing reports. This report data is from Minnesota Medicaid, or Medical Assistance in Minnesota Care. So it is just data pertaining to Medicaid enrollees and Minnesota Care enrollees. And the data in the report is from calendar year 2020. So that will be true through the life of this project. The data that is fed into the reports that kicks off the QI work is the previous calendar year. We have several exclusions in the data. We do not include patients with cancer or with a cancer diagnosis or treatment in that measurement year. We exclude patients receiving hospice services. We exclude all buprenorphine formulations and any methadone prescribed by an opioid treatment program. And that does include buprenorphine for pain, that is excluded. We do not include opioids from inpatient pharmacies. This is really about outpatient prescribing and prescribing at discharge. And then we do not include procedural and intraoperative anesthesia. So there are 7 measures included on the opioid prescribing report. 5 have a QI threshold, so they either are being considered for QI in this year or they will be in future years. And the 5 that have a QI threshold are bolded with either black or red text. But the 3 that we really want to draw your attention to right now are the 3 that have been flagged for the 2021 Quality Improvement Program. So that is measure number 2, which is the dose of an index opioid prescription. Measure number 5, which is a measure of the daily dose of chronic opioid analgesic therapy. And then measure number 6, which is concomitant chronic opioid analgesic therapy and benzodiazepine therapy. Okay, we have many resources about understanding the reports, including a great echo that Charlie Resnikoff did, who is one of the members of our opioid prescribing work group. But it's really important that anyone who's participating in this project really understands what these measures are telling you, because it impacts the kind of work you may choose for your quality improvement project. So if you feel like you need more assistance understanding what this is saying, please contact us and we can hook you up with some of those resources. But just a couple of key take-home messages. The measure 2 is our measure around the dose of that index opioid prescription. This is someone without an active opioid prescription for 90 days who gets that first dose. The really key message here is that this measure looks at the total morphine milligram equivalent of the prescription. So the MME contained in the entire bottle of tabs. So it's not a daily MME, it's a total MME. And the other thing we just want to touch on is, this measure is not intended to mean don't ever prescribe over the 100 MME threshold for non-surgical providers or 200 MME for surgical providers. But really is, if you are flagging the QI threshold, it means you're prescribing over this recommendation more than 50% of the time. And our hope is that, it would just prompt you to examine why, if you understand why that's occurring so frequently. Measure 5 is one of 2 of our measures around chronic pain, and this is about the daily dose for long-term opioid therapy. And so this is looking at how often you prescribe or over 90 morphine milligram equivalents per day to your patients. So again, this is now about daily morphine milligram equivalents, so different than measure 2. Now we're looking at the daily dose, and the correct interpretation of the measure is if you are prescribing over 90 MME beyond, 10%, beyond a select number of your cases, our hope is that you really take this time to examine why that may be the case. And then measure 6 is the concomitant measure, the concomitant prescribing measure. And similar to measure 5, we're looking at a daily dose for the chronic opioid analgesic therapy. And our hope is that if you are prescribing concomitant opioids and benzos to, more than a select number of your patients, that you understand why that's the case, and that you really feel confident that you have adequate patient monitoring practices in place, given the high risk of adverse events with this prescribing behavior. And then just sort of a heads up, our expert advisory body, the Opioid Prescribing Work Group, is spending some time right now looking at an additional measure for abrupt opioid tapers. There's a lot of concern about patient safety related to too rapid tapers and abrupt discontinuation. And that study comes from both the medical literature and the anecdotal stories that we receive. And so we are looking at prescribing data right now and looking to see if we can measure this behavior. And we will be looking at prescribing data to see if there are any changes that could signal efforts to avoid future quality improvement requirements. Okay, so moving on to the quality improvement program. Just want to take a pause for a moment and recognize that I think the safety and well-being of our Medicaid members and your patients really is a priority. We are not, looking for abrupt changes. What we really hope is that this first year is really, is really a mutual investment on behalf of the state and on behalf of your organizations and you as individuals, that we take a pause to really make an investment in that safer prescribing culture and a commitment to public health, and recognizing that systems and providers across the state have just been doing phenomenal work for the past 5 years. So our goal is just for all of us to have a better understanding of the prescribing practices, and that those of you who are involved in the QI program try out small tests of change in this year. Everybody is coming out of a very difficult period, including, we've had some challenges on our side. I don't think that they're equivalent to yours, but we hope that we have some very modest, if any, changes in the data in year 1, and that this is really just a time for us all to, learn a little bit more and do some reflection on prescribing data. Okay. So this is the general timeline, and this timeline will be true for the duration of this work. So every spring from now on, we will generate an opioid prescribing report. for anyone who prescribes opioids to Medicaid enrollees. And then for those providers who are over the QI threshold that year, in the summer, similar to where we are right now, you will submit an attestation form to DHS. And then at the end of the year, late fall, this year it's the end of November, providers will submit a completed quality improvement report to us for review. So the QI cycles really will be contained within the calendar year. And just as a reminder, the data that we use to determine your QI status is from the previous calendar year. And just want to reiterate, this year we really anticipate modest, any changes in prescribing data, given that we're midway through the next data collection cycle and all of the factors involved with the COVID-19 response and the past 18 months of all of our lives. Okay, so right now, sort of the big thing that is due to us is the completed attestation form. So that is due through DHS by August 13th. We ask that you email that in. Everyone has to complete an attestation form. I think that's really important. We sent out the attestation forms to providers and our QI liaisons on the 15th. And the attestation form is also available to download on the OPIP website. So the attestation form should be a pretty quick process. We're asking for a little bit of information, including your current practice location, because there have been changes between last year and now, just to make sure that you understand the program components and the Sentinel measure. And then if you don't understand, or if you have questions or you need support, you have the opportunity to either reach out to us and ICSI, who is providing our technical assistance and on this work, or we have also been developing relationships with organizations. So we have a QI liaison at a lot of the organizations that are involved in this part of the project. And then the other thing about this attestation form is that at the bottom of the form, there is an opportunity to request a special cause clinical review. So this is an optional form, and everyone still has to complete the attestation form. But if you believe that your practice is such that you will never be under the quality improvement threshold, this is an opportunity for you to tell us why and to do some reflection on why this may be, and submit a form to us for review. Now, Audrey's going to talk about how that's going to work, the review and the process. So I will skip over that for right now, but just please pay attention to that bottom piece on the attestation form if this is something you would like to request. And then the other big thing due back to DHS is the quality improvement report, and that is due to us by November 24th. We also emailed that out last week, and it is available to download on our website. So this should be completed after you complete your quality improvement project. This is a summary. This is your story. This is what you will do at the end once you're done. So the report is designed to track with the ICSI opioid prescribing improvement guide. If you hold up the two documents, you'll see that there's strong similarities, but it was also designed that it could really capture, the things we want to know about any quality improvement program. So any plan, do, study, act cycle, it will translate nicely into that report. So when the reports are done, they will be reviewed by DHS, but they will be reviewed by your clinical peers. So what happens when the report is submitted at the end of the year? You will receive feedback on your report, and that will happen in early 2022. And so that will come before the next annual opioid prescribing report cycle. And then this this is the first year we're doing this. So we are going to learn a lot as we get this information back as well. But in general, what will happen is, if you remain over the QI threshold for the same measure where you're doing quality improvement work in 2021, we will ask that you continue in that area of prescribing. We will open up the quality improvement next year to the other measures that we didn't include in year one in order to keep the scale of the project reasonable for the first year. So if you're over the QI threshold on a new measure, another QI project will start. And then if you aren't over the QI threshold anymore, there won't be additional quality improvement requirements. But I do want to stress that we are going to be looking at prescribing data for those participating in the project to, put some guardrails and make sure that there's there's nothing going on that would signal, maybe an effort to get out of the work. Although we don't think that will happen, we will be doing that. Okay, so there's a host of people available for support. As I mentioned, we have identified contacts in your organization. So if you don't know who you can reach out to in your organization, please contact us and we can connect you with the person who has been identified to work on this project. We are working hand in glove with the Institute for Clinical Systems Improvement, and that includes Audrey and their whole team. And then our staff keeps getting deeper as we go through this project. So if you have any questions, we ask that you email our dedicated inbox for this project, which is dhs.opioid@state.mn.us. And our team includes Jessica and me, and Ellie Garrett, who's our supervisor. David Kelly is our data scientist, and then Dr. Nathan Chomolo is also involved in the work. And we will keep the OPIP website as up to date as we possibly can with the information you need to know and the resources that you need to complete this project. And the URL is on the bottom of this slide. So right now we will pause and take any questions that may have come through in the Q&A. And Jessica is going to moderate that.
Hi, everyone. My name is Jessica Hultgren with the DHS staff. So far we only have 4 questions. So I think there's 2 that I'll quickly get out of the way and then pass the remaining 2 to Audrey. So the first question is regarding attestations and who needs to complete an attestation form. The answer to that question is only your providers who have been identified to participate in quality improvement have to do the attestation. So if there are other providers in your organization who received a report but aren't a prescribing report but aren't identified for quality improvement, no attestation is needed. The next question is regarding a provider who retired. How should an organization notify DHS of any provider changes? The easiest way, and we do welcome any information of that nature, the easiest way is to email us at the email Sarah shared on the previous slide. So any providers who have retired, moved out of state, unfortunately we've had a few providers pass away, all of those are changes that we would like to be aware of. So there are 2 questions here that I'm going to hand off to Audrey Hansen from ICSI, and she will cue those up.
Helps if I unmute. Hello, my name is Audrey Hansen, and I am with ICSI. So the one question that I do have to the DHS team, one of them says, how do you capture patients that are comfort care but not on hospice? And I don't believe there's an exclusion for that in the data. Am I correct, ladies? We don't have a palliative care exclusion. So it is only if there's a bill for hospice that would trigger something like that. So if you have providers who are dedicated to palliative care, then perhaps you should indicate that to DHS as that being their specialty area, and then you'll probably want to do a special cause form so that people understand what your practice is. Unfortunately, they are not always labeled very clearly in the data, so it's really hard to find them. Okay, and the next question was, is there any consideration for excluding long-term care residents or transitional care unit patients because these patients often have chronic pain or acute pain in the TCU setting? And no, there is not. The reason why we don't exclude them is because they're at very high risk, because at that age, they should probably only be getting half the dose that you or I might get. The acute piece fits in with the acute care. So if they're fresh post-op, they would be receiving up to 200 on this particular program. They'd be getting up to 200 without being flagged for threshold. If they're a major joint patient, if that's primarily what your facility does, is manage like if you have a contract to manage all the total hips that come out of the hospital, then tell us about that. Do a special cause form and tell us what your population is. But skilled nursing patients who have chronic pain are exactly the same as a patient in the community who has chronic pain. And at that age, they actually need less. So hopefully that answers your question, but there is no exclusion for them. So I don't see any other questions. I'm going to go ahead and share my screen and start mine as well. As I said, I am the project manager at ICSI for this work. I'm a nurse by training, and I've been working on this for several years as well. And so I'm going to go to a couple slides here. There we go. So one of the things that I wanted to share with you is just the idea that a lot of the quality improvement work, as Sarah said, is based off the ICSI Opioid Prescribing Improvement Guide. And this isn't the only tool, but it was designed to help you do exactly what you're being asked to do. And it's specifically focused on opioids, and it covers acute, subacute, and chronic pain. It includes a lot of information that could potentially be helpful to you. Maybe not all of it, but some of it at least. So you can see in the corner here that there's, the Plan, Do, Study, Act is a pretty common piece, but what we added is the parts in the beginning where you need to understand your practice. So we're hoping that you would take a look at that. DHS asked us, after this group of people, these group of organizations worked with ICSI to create all of this information over 4 years, this and the postoperative toolkit. And they asked us last year and funded us to put this all in writing so that it can be used by anyone across the state now that the work has finished. So thank you to all these organizations. The guide includes a basic improvement model, but it also has an appendix on systems leaders guide. So our CEO at ICSI, Claire Neely, Dr. Neely, will be presenting on Friday about how to use the system leader guide. I highly recommend it if that's the position that you're in. It has recommended standards of practice all in one place for ease of use. There are sections on understanding challenges, stressors, barriers, and identifying your assets, resources. And then there's a great appendix summarizing some tested strategies that all of these organizations were able to compile with us over the years. And then the Plan, Do, Study, Act piece and general resources with links available with tools. It's got a lot of information for you. So understanding your practice really is kind of figuring out what's available and who can help you access it. And that's why we focus so much on you having someone in your organization who can be your quality improvement contact to help you find some of these exact things. So we want you to look at your whole practice and not just this sliver of the pie. How does your current system, clinic, or department manage data? Maybe they have data available to you already, and your EMR might actually have a dashboard for opioids that you may or may not be aware of. Have you reviewed your printed your PMP report? That contains a lot of information and can give you a lot more of the breadth of your practice. And then sometimes health plans will share you data. If you have some already, look at it. If you don't, you might ask them for it. And then have you done a chart audit recently? That's very telling usually. It's not also just about your opioid prescription. We want you to consider, are there other things that are the non-opioid community standards that you could put in place for your quality improvement to help your pain patients? So since DHS reports only that Medicaid population, we suggest that you take your overall data from the previous slide that you have found and look at that compared to your report card from DHS and look at the accepted community standards to find the gaps and the differences. And when you're looking at these, it's important to have a common metrics. So DHS, ICSI, and several of the health plans and organizations, CDC, have all selected morphine milligram equivalents as the measure, MME. And that is what has been prescribed, not pills or days, because literally pills or days of what? So there needs to be a clinical dose that everyone can understand this patient is getting. So we're asking you to make sure that you understand MME and that you build it into your system. So when you're looking at data, you want to look for the acute episodes, you want to look at the total prescription that was written. So that's called total MME per prescription. For chronic uses, we want to look at the daily MME of all the doses combined. So some patients might be on long acting and they might have a short acting for breakthrough pain. So you want to calculate what that daily dose is based on how it's prescribed so that you don't exceed the threshold or the recommended amounts for the patient. And then the last one, if you prescribe for postoperative pain or for procedures, you may want to compare your average total MME discharge prescription for specific procedures. So as you're discharged from a facility post-op, what is that ambulatory prescription and what's that total MME written? Like Sarah said, what's in the bottle? The other thing is that if a patient is discharged from the hospital to a skilled nursing facility or a transitional care unit, that's considered an outpatient discharge prescription. So if the surgeon does not prescribe it, but the receiving long-term care facility does prescribe it, it is you, the facility, that has that report on yours. So just some things to think about. Okay, so the improvement guide, like I said, is not the only one, but it does include recommended standards and processes for ambulatory opioid prescribing and general management, and it's by pain phase. So those recommendations are on page 6, and we're going to show a little snippet of them here. But we want you to find the potential gaps in your practice related to the standards and pay specific attention to the pain phase that you exceeded the thresholds on. Talk to your team about the gaps and why it's difficult for you to adhere to those standards. They will probably have a lot of really good information for you to work with. And review 10 to 20 charts. And when you look at those charts of patients who received opioids, look for what was the diagnosis. Was it an appropriate diagnosis to start an opioid at all? What is the MME that was prescribed? And then were there contributing workflow issues that might give you information about your prescribing practice? Maybe you're the one that always ends up doing the refills. And so you might show up on that report in the future as having more than 700 MME cumulative over 45 days. Those are little things that the workflow will inform you about. And then share your findings with a peer. Get together with other providers and let iron sharpen iron so that they can say, you know what, for this patient, I think you could probably change this. This one is the standards for acute and subacute pain. And as you can see on the on the left side, there are not only MME recommendations, but there are other recommendations in there, like paying attention to your acetaminophen dose and instructing the patient what to do if the pain doesn't resolve. And then there's post-acute or episodic pain, followed by post-op pain. These are just snippets for people to call your attention to. The universal actions on the right include things like communicating realistic expectations to your patient and educating the family about safe use, storage, and disposal, checking the PDMP. Those are the non-opioid prescribing pieces that we also want you to pay attention to as you think about how you can improve your practice. And on the bottom is a list of the things that have been identified by literature that promote or lead to or suggest a pattern of chronicity. So if you have a patient who received more than a 10 or up to 30-day supply of opioids in one prescription, chances are a year later, they will still be on opioids. So this is what literature is showing us, so we're just sharing it. And then the chronic pain piece talks about the standards for chronic pain, but on the right, it also has red flags for opioid use disorder, all in one place for you to remember that these are signs that there is opioid use and opioid use disorder, and that these patients will need some follow-up. But again, the reminder, as Sarah said, do not abruptly stop opioids. That's a very dangerous thing for the patient to do. So I want to talk a little bit about the special cause request for clinical review. This form was developed for the purpose of allowing prescribers to explain why they prescribe outside the accepted community standards. And then while honestly, everyone in that opioid working group believes that there's opportunity to improve prescribing. They believe that, but they want this process is going to help DHS understand where special cause exists. So we want to hear your story. The form is designed to work you through a few steps to assure that you understand how you compare with test standards, how the prescribing patterns are for the whole patient population, and potential issues within their team or their clinic workflows that may contribute to that prescribing pattern. I also want to mention for surgical specialties and special cause that we do have, as I said, the postoperative prescribing toolkit. These are both available on the ICSI and the DHS websites. In this toolkit, the appendix has a list of procedure-specific MMEs for the initial discharge prescription. So review the toolkit for the general recommendations for improvement, and then find your surgical specialty in the appendix and assess the gap between your prescribing and management and the community goals. And one thing I want to call out here is that it is a confusing state that DHS has a benchmark cap at 200 MME for surgical procedures. If you look at our recommendations, you'll find that most of the procedures in there have a benchmark lower than 200 MME. So they weren't far from right on that. But that was a long time ago. They made that decision, and there's been a lot of work with surgeons through the ICSI collaborative to understand what is the right dose for each procedure. So many of them are lower than that. And there are a few, especially some of our orthopedic and spine procedures, that could potentially be more than that. So look for those and understand where you're at compared to what the DHS standard of 200, that's why you were flagged potentially in the prescribing number 2. And understand where you are compared to the benchmark goals that are on the appendix of the postoperative toolkit. And then why you might be over those thresholds. And then what is your current average? What are you looking at right now? So how are you doing on those procedures? And what have you done to improve your prescribing? And when that form comes back to us, it will help us respond to you very quickly, because many of you have been working on this with us actually for quite a while. And we just want to make sure that you personally, that each prescriber has made an attempt to make a difference in their prescribing. So the submission process is, as Sarah said, the attestation form is due by the 13th of August, and individual prescribers can request a special cause request either on the attestation form or through their QA liaison, or they can email DHS. And prescribers are encouraged to work with their available QI supports to help complete that process as soon as possible and to get it back to DHS by the 20th of August. Once we get it, the committee of physicians, subject matter experts, and staff are going to review your request within 30 days of receipt. And some prescribers may be asked to do a modified or shortened QI by November 24th, but some providers may still need to do the full QI. So that's why we need them soon, so we can get it back to you. I just want to call your attention to the fact that ICSI website has a lot of resources. The first two, the improvement guide and the prescribing toolkit, were sponsored by DHS. We also have an improvement story for post-op that has a lot of the local data in it as well, and more advice for how to do it. And then we have supporting material on substance use disorder and tapering and medications for opioid use disorder. And that was sponsored by MDH, the MOUD. And then we have clinical guidelines with a lot of opioid content in them. They've been updated recently. So pain, perioperative, low back pain, and palliative care guidelines are all on there. I suggest that you download those documents and keep them for yourselves. And future webinars are here. They're also on the website. And as I said, on Friday from 12 to 1 will be the Leading Your Organization Through Change with Dr. Neely. These recordings are on the website in the future, and they will also include the transcript for you as well. So at this point, I'm going to stop sharing and open it up for any questions that may have come up.
Thanks, Audrey. So we have a question here. Do you compare by practice specialty, for example, geriatric versus surgical, or by credentials? And the example given was a family practice doctor working in geriatrics. So I will pass that one to Sarah.
We compare your prescribing by your specialty. So if the example is a family practice provider working with a geriatric population, you're going to look like a family medicine provider in the reports, and you'll be compared to other family medicine providers. And so the short answer of why that is the case is we have a few specialties that it's really important to have, to identify some of them based on their opioid prescribing behavior. And we needed to keep those specialties broad enough so that we didn't risk sort of identifying who the providers are in that specialty, because some of our groups are smaller than something like family medicine. We are always open to suggestions on how to do QI to our own work. So this has actually come up before, the family medicine with a geriatric specialty. So we always welcome that feedback, but the short answer is it's by specialty. And the only place that really has a big impact is in the acute space, because surgeons have a higher dose threshold on measure 2, and we don't have a quality improvement threshold for measure 1. It's not relevant to this year, but it will be relevant going forward. For everyone else, the QI thresholds are the same across specialties.
Thank you, Sarah. The other thing I will add is all the averages for the specialty groups that we formed are available on our website. So if you're curious about checking out other averages that are related to your practice, those are available. The next question we have here is, what if I don't follow through with the quality improvement process? What is the penalty? Sarah, would you like that one?
Sure. So I really hope you do. I mean, we've been really working hard to make this a meaningful and worthwhile use of your very busy time. So I hope that you do follow through. This year is not a very heavy lift. It shouldn't take too long. But the statute that authorizes this program gives us the following authority. So we have this first year, and if someone doesn't participate or participates in a way that the peer review says this really isn't QI, we have the authority to escalate the requirements of you in year 2. And I hate to even talk about this, but this is the authority granted to DHS, is that under this project, we have the ability to disenroll providers from Medicaid. And that is the work that the opioid prescribing work group is working very hard on right now to define what that means. It's a big deal, and we hope we never ever have to do it. And we're working really hard with our opioid prescribing work group and our other resources at DHS who do this kind of work to make sure that this is done in an extremely fair way. It would be a very a process that would really, give anyone who is going through this due process and appeal rights. And so I don't want to scare anyone, but I do want to acknowledge that we do have the authority to take action against providers who don't participate in this work.
Thank you, Sarah.
I have a question that we've received, not in this webinar, but in a different one. So one of the questions we've received is that when we've previously talked about this project, it initially was thought that the quality improvement would look different for providers who are flagged on measure 2, which is prescribing for acute pain, versus measures 5 and 6, which is prescribing for chronic pain. So at this point, this same, activities are expected for all providers, regardless of which measure you are flagged for quality improvement on. And the thing that we didn't mention today is that in addition to this work on the quality improvement project, we are also refining our work on chronic pain. So with ICSI support, we are convening some really exciting groups to just do a deeper dive to help us understand where the gaps are and why the gaps exist between, the guidance around chronic prescribing for chronic pain and the experience of providers and patients in treating these patients. And we have providers across the state involved. We have a cohort of patients involved. It's going to be really exciting work. It's going to help us develop some principles around chronic pain that will be used more in year 2 of the quality improvement work. And it will just help all of us better understand this, very challenging clinical, I don't want to say clinical situation, that sounds negative, but we are refining our work to better understand and better support providers doing QI in subsequent years.